This is our first edition of Ask the Doctor. Thank you. We're super, super, super duper excited to be doing this because we believe that we're going to be blessing, it's going to be blessing life, not us, but the information that people are going to get from Ask the Doctor, the clarity, the direction is going to be helping a lot of people. So if you're already on air, share it on your different platform, invite your friends. If you have a woman in your life, a girl child, whoever, even a man, support system. We're big on support system. So please invite them, let them come in, let them please share on your platform, on your status that we are in the next 3 minutes we're going to be starting. So we're just waiting for people to trickle in to join us. We're on live we're on YouTube as well as on Facebook. We're on YouTube as well as on Facebook. So, and we have our very own Dr. AY. Is going to be breaking things down for us. So please put down your questions, and we're going to be answering some questions today. We might not be able to get to everything, but we will try as much as possible. We don't want to keep you here for a very long time, so we'll try as much as possible to touch um, the questions that we can touch. The ones that we cannot get to, we will. This is a monthly program. Will be going live every third Sunday of the month. And so, if we're not able to get to your questions today, trust and believe that we'll definitely get to it next month, or even you can reach out to us on our contact. We have some of our LifeBloom team on different platforms. Please put in Bidemi Moson, please put in our contact information so that people can reach us on there. I think we just lost Dr. AY. I'm sure he will be joining us again. He will be joining us very soon. Okay, he's right here. All righty, all right. So we have 1 more minute to go, and we will be starting. We have 1 more minute to go. All right. It's 6 p.m. on the dot and 6 p.m. West African time and 12 noon Eastern Standard Time. And we don't want to keep people waiting. We want to be people of our own words. We have said we're going to start at 6, and so we're going to um, kick it off by starting, and I'm sure that other people will join us. Thank you so much for joining us. Thank you for joining LifeBloom with John. Thank you for joining LifeBloom. We truly, truly appreciate you. Welcome on board. Welcome on board. Again, if you're new here, my name is Joanne Oyedokun, and I am privileged to be the founder of LifeBloom. And what do we do at LifeBloom? LifeBloom is just an organization that creates awareness, talk about advocacy, empower women about women-related issues, especially in the area of reproductive issues like endometriosis, like infertility, PCOS, fibroid, and all other things. And we also talk about how all these things come together and affect our mental health, affect our relationship, affect every part of our being. So that's what we talk about at LifeBloom, and just give a support. We have a safe place, which we have a community on WhatsApp. So you also see our community form somewhere on either on Facebook or on YouTube. You can click to join our community. It's a safe place where we come together, we rub minds, we brainstorm, we share. And so basically it. If you want to know more about LifeBloom, please go on our pages. We are on all on social media, all different platforms on social media, and we also have our website. Please click Musumbiremi, please click pin our website on the live so that people can see it and all our pages. Thank you so much. So today, like I said, we'll kick it off, and this is our very first edition of Ask the Doctor, and I am so honored and so grateful to be here, to be joined by one of the very best doctors in Nigeria. Honestly, yes, I said it, and I will stand by it any day, anytime. And he's my man. He's my husband's best friend. He was actually our best man on our wedding day. So you know how very, very, very close he is to us. Thank you so much, Dr. Ayo Olowo Kere, for joining us today. So I will give Dr. Ayo some few minutes before we dive into the question, just to introduce himself, and trust and believe if he doesn't do a good job, I'll come right behind him and do it and do justice. So let's roll. All right, over to you, Dr. Ayo.
Uh, Thank you very much, Funke. I'm really, really happy to be here. I'm privileged to be here. I can tell you for free that I'm just one of the few privileged doctors still remaining in Nigeria, and we are trying to make our own marks in the sands of time. My name is Dr. Caleb Ayorin Kere. I'm a member of West African College of Surgeons. I'm a fellow of National Postgraduate Medical College of Obstetrics and Gynecology. And by appointment, I'm a consultant obstetrician and gynecologist working with Federal Medical Center, Ikole Ekiti. Well, it's a passion, it's a calling to take care of women and to ensure women live a very healthy life, most especially as in aspects that has to do with their reproductive careers. And it's actually a thing of joy. It's a privilege to be called among the many to take care of women who are actually the people that make the world go round. I keep saying it that keep one man, kill all of the men, kill the women, the world will continue. But if you take out all the women, the world will go into extinction. So in the real deal, the women are the real deal around. So we should throw our weight behind them. Make sure that they live a painless life, a very stressless life, and the world will be a happy place. Thank you very much.
Thank you so much, Dr. Ayo. Thank you. And honestly, this is so, so, so special in a way that honestly, I can remember when I was going through my own ordeal with endometriosis. Dr. Ayo is one of the few people that knew what I was going through, as in the pain level, how I struggle every month, how I'm completely shut down and shut in for a whole week when I'm on my period and all that. He and my husband, then my boyfriend slash fiance, whatever you guys call it these days. Then so this is a real full circle moment, so to say. But thank you for joining us. Thank you so much. So let's start by, I want to ask you, what exactly is endometriosis? For those people that don't know, and I don't want you to, I know that you are a consultant, you're a doctor and everything, but please and please, I want you to break it down to the barest minimum that anyone and everyone watching on here today will be able to understand what exactly endometriosis is.
Well, I'll try my best to be as make it as simple as I can. Our medical jargons will keep coming in once in a while, but I'll try as much as possible to make it as simple for the audience to
Yes.
digest.
Yes.
Well, actual fact, endometriosis appears like a big word. It's actually a very big, long name that will actually twist the tongues of a lot of people. And but it's actually a very simple thing. Let me just explain it like this. I won't define it. I will explain it. Because if I define it, many people will not be able to appreciate what I'm talking about. Now we all know we have what is called womb. I'll use layman's terms, please. Just pardon me. And for the
Yeah.
medical personnel that will be joining us, please just allow me use layman's language. Okay. Womb, also known as the uterus, is what is the part of a woman's reproductive organ that carries babies when women get pregnant. And it is also the same womb that menstruates every month. In fact, we call menstruation the disappointment or disappointment, no, the weeping of a disappointed womb. Yes, that is the womb that is weeping every month. Oh, you didn't give me baby this month, and the womb is trying to cry and tell the woman, oh, I'm supposed to carry a pregnancy, you didn't give me. That's why menses come up. So that the womb has different layers. The part of particular interest is the innermost layer of the womb that we call the endometrial layer. We have the serosa, the myometrium, the endometrium. So that endometrial layer, the endometrium, it has a capacity of growing. It responds to the hormonal environment produced from the ovaries under the influence of the brain, the higher centers, and among other things. So it responds to these hormones called estrogen and progesterone mainly. And that part of that endometrial layer grows. It becomes laden with blood. It's actually preparing a waterbed for a potential pregnancy that will ensue from the ovulation that occurs that month. So once the ovulation occurs, the waterbed has been produced in the womb, receives the baby, and the baby starts growing. It is when the baby doesn't arrive that the waterbed has to be shed. And this happens in menstruation at the end of the month. So that's menstruation. Now, if you now find these glands, the endometrial layer contains glands and stromas and some other elements that can respond to hormones. So if you now find this particular responsive gland that looks like the endometrial layer in places other than the inner layer of the uterus, that is endometriosis. So now it's only meant to be within the inner layer of the uterus, and that is where its business is. It's meant to respond to hormones, become thicker, accumulate blood, and increase in thickness and all that. Then, if once this doesn't happen, sheds in menses. So you can now conceptualize finding this kind of glands in places that are not within the uterus. For example, if you find it in the pelvis or in the ovary, because ovaries are the nearest neighbors of the uterus. Ovaries are where the eggs are. When the eggs get released, the uterus picks it up via the fallopian tube, which everybody used to hear fallopian tube in biology.
Mm-hmm.
So the fallopian tube picks up the egg, then the egg stays inside the fallopian tube. During sexual intercourse, sperm also goes into the uterus, enters the fallopian tube, and fertilization occurs. Now, the nearest neighbors of the uterus are the fallopian tube. Now, imagine these endometriotic deposits being found in the ovary. So that means the ovary will keep bleeding every month. We keep getting laden with blood every month. We keep bleeding in it, and there's no way the ovarian function can be preserved. Now imagine you finding it on in some other dangerous areas like the brain, for example, which is possible. That means the patient will be bleeding into the brain every month, and that one can lead to a lot of things. Can lead to intractable headaches. Can lead to funny symptoms like even seizures. Some people can have
Mm,
behavioral. Some people can have stroke-like.
really?
Yes, it can. It's that bad. And okay, if you find it like that, let me give you an example of one patient that called me in the middle of the night one day around maybe 1 a.m. thereabout. She thought she was dying. She had cesarean section surgery. Some years later, then she just noticed that there is eye bleeding from the navel. So she thought she was having a cancer. She thought she was dying. So she was so scared. Ah. So, but she didn't actually tell me what was wrong. She just told the doctor, I'm dying. So I said, okay, wait. I'll get to you as soon as I can. By the time I got to the woman, I saw her bleeding from the navel. And she's been to some other doctors that said, oh, this is terrible. She will do MRI, she will do abdominal pelvic CT and all that. So I just asked her a simple question. Madam, are you menstruating now? She said, yes. What has that got to do with the navel that was bleeding? I jumped, I just landed on the chair and I started laughing. I laughed well for like 2 to 3 minutes before I answered that, look, you had an endometriotic deposit on your navel. And because you are menstruating, that is why the endometriosis too on your navel was menstruating. And look, and I examined, I saw the deposit there. It was just there. I said, okay, let's see. When your menses stops, let's see whether the bleeding will stop. And that was it. So it could be anywhere. And endometriosis like that is actually commoner than we know or that we thought. Because there are lots of things that could result into endometriosis. For example, you find endometriosis in about 3 to 10% of women in reproductive age group. You know how many women in the world? About 7 billion people in the world. I'm sure out of that 7 billion people in the world, we have about 4 billion that are women. And now, the percentage in reproductive age group, you have about 10% of them carrying endometriosis around. And they may not know, depending on the severity. And for about 35% of patients that are unable to achieve pregnancy, it's caused by endometriosis. That's huge. For patients that just come around and look, doctor, for one reason or the other, maybe I have a fibroid, maybe I just have some issues, abnormal uterine bleeding, I'm not desirous of fertility, and you want to remove such uterus, you find endometriosis deposit in the muscle layer of about 10% of such uteruses. So it's common. And the unfortunate thing in our environment is the gold standard for the diagnosis of endometriosis is laparoscopy, and it's not readily available. It's expensive for the centers that have it, and really can't put our hands on it. We have few laparoscopic surgeons around or specialists around. We have few laparoscopic equipments around. Send that link to our people so that they can join. So you have that. Laparoscopy is not readily available, so we really cannot diagnose as much as we can. So, and that's a problem. Then, presentation of endometriosis, it of course, I've told you, it depends on where the endometriosis deposits are found. It can present with infertility, it can present with menstrual pain, it can present with excessive bleeding of the uterus, excessive menstrual bleeding, it can present with all manners of things. So it all depends on where the deposits are found. Some people have menstrual cramps. That it's the gynecologists that understand all this, and it's usually very funny. When your menstrual cramp way back then, we were students, we really did not get it. But the endometriosis was telling us, this is me. The kind of menstrual cramps we suffered when we were in school, when we were neighbors, when I was peeping across the fence, when I would jump across the fence, come and stay with you. So then it was classical. But because we were just students and we knew close to nothing, we could not pick it up. And then
Thank
way
God that
back,
you said that. Thank God that you said that. I asked my husband,
we didn't know.
because
That's
I
the
asked my
funny
husband
part.
the same time. I was like, so did you know that I was dealing with this thing called endometriosis or whatever? He said he knew that my period was really, and obviously you both knew that
Dreaded.
my period was, yes,
Good.
way out of hand, but that they studied endometriosis in school. You guys studied it, but you never saw.
No, let me defend. Let me defend us. There, way back then, we had there were no laparoscopy when we were in school. Let me tell you that for free. We were
Wow.
not trained in lab. There were no
No
laparoscopy.
wonder I was being dismissed
Diagnosis,
several times.
the diagnosis of endometriosis was elusive. It was not readily available like it is now. We were not trained. As a student then, I barely knew anything about laparoscopy. It's not so popular in Nigeria way back then. It's been a long while. We did these postings. This time we're talking about 2000, about 26 years ago. It's not easy to make such diagnosis way back then. And of course, it was what was available that we will know. So very well, very very unfortunate. Thinking back, I
Very,
really
very, very, very. And it's so
you really
sad
suffer.
because it's very unfortunate and so sad because that explains why a lot of us get dismissed when we go to doctor. It's a couple of things that we get dismissed. Some of us go to our primary doctor, which is one of the things that I was doing then. And so, they were just talking me out of it, giving me pain medication and all that. I wasn't seeing the specialist. I wasn't seeing a gynecologist who I was meant to be seeing. That's number one. But number two, even if I was in the gynecologist, there's every possibility that the gynecologist will dismiss it because as like when we were talking, you know, maybe they don't know so much, maybe they've just studied it or trained for it, but they've never seen the practicality of it, you know. And it's still so funny that even up until now, we're 7 to 10 years behind in diagnosis. Why is it that even up until now, I get it then, Dr. Ayo, but even up
Yeah.
until now, we're still way behind in diagnosis. So when a young girl in her teens starts menstruating and she starts experiencing all these things, when if it's not for organizations like LifeBloom that is now creating the awareness, talking about it, spreading it, there's every tendency that that girl will go and she'll get dismissed, like I was dismissed, and she won't get the diagnosis of whatever she's going through, at least for the next 5 years. So, what exactly is the problem?
I didn't get that.
I'm saying that when I was having the issue then, you know, I guess there was no, the medical world has not evolved
It
as much
was. It
as
has
it is right now.
not popularized around us.
Yeah, but now, things are, there are a lot of knowledge, a lot of information out there, but we're still 7 to 10 years behind in diagnosis of endometriosis based on research.
Okay.
So why are we still behind as much as that? Why should why should a young girl still have to deal and suffer with pain for that long before she get diagnosed and start treating and navigating through endometriosis?
Well, hmm. I let me first let me start from this that I really give kudos to Nigerian doctors or probably African doctors, most especially Nigerian doctors, because our diagnostic acumen is top notch. Even though we really don't have much to work with, we still come around and diagnose this. There are ways Nigerian doctors find a way of just getting things done, no matter how restricted resources are, and we still help our patients as much as possible. Even though laparoscopic procedures or machines or facilities are not so readily available around us, we still pick these conditions from history. When a patient comes around, there's this classical history they give us, and you can actually suspect endometriosis from it. So now the question is, can the patient afford laparoscopy, which is the gold standard? Because to be candid, ultrasound will not see it. It might
Mm.
just see things that suggest pelvic adhesions or pelvic masses. It's not going to put a lead on it that, oh, these are endometriotic deposits or nodules. But we still help our patients. Now, the history of importance. We are not teaching people medicine, but the reason why we are doing this is to educate as much people as we can. You know, there's something called primary dysmenorrhea. Primary dysmenorrhea is the normal menstrual cramps that is usually physiological. That when somebody is about to menstruate, probably 12 hours, 24 hours sometimes, when the menstruation is about to come, the person starts feeling cramps, low abdominal pains that radiates to the back, pick up a leg and all that. It comes and goes, and it's usually depending on the physiological response to menses. It might not be so severe. Some of them can be mild and all that. So the reason why this primary dysmenorrhea occurs is because of prostaglandin synthesis in the uterus. The prostaglandins are meant to squeeze the uterus to allow the endometrial layer to shed. But some patients produce a lot of prostaglandins, so the contraction of the uterus during the menses becomes more vigorous, so they feel more pain. So depending on the physiological events, some people feel pains more than others. And that's simple, and that is primary dysmenorrhea. But in situations where you now have a pathology, being responsible for the pain becomes a secondary dysmenorrhea or secondary menstrual pain. One of them is endometriosis. Now, there's a way endometriosis pain presents. It could present, okay, let's bring it home. It is caused by bleeding into abnormal spaces. And that's
Mm-hmm.
why, for example, there's a kind of endometriosis that could be found inside the muzzle of the uterus itself.
Mm.
Because I've told you the endometrial layer is just meant to be within the innermost layer of the uterus. So if it's found anywhere else, it is abnormal. So in some situations, you find them inside the muzzle bulk of the uterus. The uterus has a coat called the serosa, that's the muzzle bulk, then that's in the endometrial layer. So that we call that one adenomyosis. Now imagine somebody bleeding into the muzzle bulk of the uterus. The uterus will be contracting against an island of blood, and it's usually going to be painful. Now this is it. The pain starts when the bleeding starts. So the patient starts feeling pain when the blood starts coming out from the vagina, and the pain worsens as the menses progresses. You understand? As the menses progress,
Mm-hmm.
rather, pain worsens. Remember, in primary dysmenorrhea, it is just caused by physiological production of prostaglandins. In fact, in most cases, by the time the menses starts coming out, the uterus would have seen that, oh, I've achieved what I want to do with this prostaglandin, shuts down the prostaglandin since the menses is already coming out. So the pain stops like maybe 12 hours after the menses are started. Do you understand? It starts before the menses comes because the uterus is trying to send out the endometrial, the laden endometrial glands. It wants to send out the blood, so it produces prostaglandins. So the pain starts before the menses actually comes out, lasts into like maybe 10, 12 hours, rarely 24 hours after the menses are started coming out. But
Mm.
in this condition, the pain starts when the blood starts coming out because it's caused by irritation of tissues, and it lasts throughout the menses because as the menses is coming out, this blood is accumulating elsewhere also. It's bleeding, the tissue is bleeding into a space. That's what's causing the pain. So the pain lasts throughout the menses and even outlast the menses. Sometimes when the menses are stopped, the pain still continues because the blood has been there until the body absorbs the blood, the pain doesn't stop. And as the menses progress, the pain worsens. So when somebody gives us such classical history, we are suspicious. This is looking like endometriosis. And that's because of the kind of training Nigerian doctors have. Because we have limited resources, to be candid, and we must help our patients. So we tend to want to work with what we have, and just stick on it. And just stick on it. Are you
Okay.
getting my this thing?
Yeah,
So
yeah.
now,
And thank you,
now
thank you for
go for laparoscopic procedures. The question now comes, can they afford it? That's where the
mm,
government.
yeah.
So the doctor to be sure to put his foot on the ground that, oh, this is it. The patients, most of our patients belong to low socioeconomic status, and many of them do not have the wherewithal to do some of this
Okay.
investigation.
Okay, yeah, I know that endometriosis can only be diagnosed with laparoscopy. That one has been established. But in situation from what you have said, in situation when we have, especially with African countries, where we
Yeah.
don't have enough medical resources, economical resources, and all that, and people cannot afford it. There was a time I think I don't want to mention the name of the country in Africa that I was trying to Google how much it cost to do a laparoscopy, and when I saw it, I opened my mouth. I was like, "What?" So in a situation where a young lady or a woman has been going through pain, da, 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 and she cannot afford laparoscopy, what are the Can you give us some clear signs that we all need to pay attention to, maybe as a mother, or even as a father, as a parent generally? You have a
Yeah,
daughter that is
and,
presenting with pain and all that. What are the some of the symptoms that this thing presents with, so that when they go to see the doctor and they are being dismissed, they can keep going and telling the doctor that there's more to this thing?
yeah, I've said one of the most
Yeah, you've
important
said one.
symptoms, that the symptom that a patient can easily pick. So once your menses behaves the way I just described, you should be suspicious. One thing I like about maybe developed countries is an average person knows at least about 40 to 50% of his or her condition. But in our environment, we have several other people that will keep lying to the general public, and the little knowledge people have, they water it down. They give them negative knowledge that will counteract the little we are trying to do. So now, pain may be a presentation, and that's the characteristic of the pain. And I think we understand why it's like that. And then some patients may actually have heavy menses. Like for example, I told you the uterus, the womb, is a very beautiful organ. It's a muscular organ. The blood vessel that supplies the womb passes through, the different layers of the muscle bulk of the uterus. Very beautiful organ, wonderfully beautiful organ, because the arrangement of the muscles of the uterus are in three layers. You have the oblique arrangement, the transverse, and the longitudinal arrangement, and they move in intercalcing manner, such that they move at a particular angle to each other, that the blood vessel that passes through them, once the uterus contracts, it squeezes the blood vessel and prevents excessive loss of blood. So that's a mechanism. Now, in a patient that has islands of blood within the muscle bulk, of the uterus, you agree with me that contraction of the muscle will be difficult in such situations, because the we call it hematoma, the blood collection within the muscle bulk of the uterus will not allow the uterus to contract adequately, thereby sealing the sinuses and the vessels within the uterus. So as a result, such patient might bleed excessively. They may have what we call menorrhagia. So when you see somebody bleeding excessively, adenomyosis is a culprit. You get? So painful menstruation, and for someone that's bleeding excessively, that's still bleeding into islands within the muscle bulk of the uterus, the pain is endless. They can bleed. There are other conditions that can cause excessive bleeding though. Fibroid is one of them. Dysfunctional uterine bleeding. There are so many, but endometriosis is one of them. Then you can start having irregular menses. The menses could be regular. I put it to you. Let me just tell you something. All these things, we are not, medicine has traversed where we hide facts from patients. Now we want the patients to know, so they can help us take care of themselves, so we can achieve the common goals together. For example, I won't give you a drug without telling you the name and the possible side effects. So if you know what the drug is going to do for you, you are going to be compliant, because you'll be happy taking your drugs, because you know if you don't take it, this can happen to me, this can happen to me. And when you start having adverse events or adverse effect of the drugs, you know already, my doctor has told me. We may not be able to say everything, but at least we tell you the common ones. Now, if a patient is menstruating regularly, that's why I gave a background to this. If a woman is menstruating every month, there's more than 90% chance that she's ovulating. So you should just put that in your pocket. That for the fact that you are menstruating monthly is a sign. It's not absolute though, but it's a signal that, this cycle is an ovulatory cycle. Now, if the cycle is not ovulatory, the patient may not be menstruating every month. So irregular menses. So in other words, now I told you, the nearest neighbor of the uterus are the ovaries, and that is where the eggs are produced. Let me just run through it, run you through it. We
Ah,
call some
don't
of the body.
don't don't run us through it too much. We have two questions that we
Uh,
have received
no,
from
let
our
me just
audience.
let me just take this one.
Okay, okay.
The ovaries respond to the higher centers by forming eggs. that the woman is going to release at ovulation every month. These eggs produce hormones that act on the uterus to form the waterbed that prepares for the reception of the babies when pregnancy ensues. Okay, fine. If the ovaries are laden with endometriotic deposits, how will they do their jobs? How will the progesterone, the estrogen hormones get produced? So, in other words, this woman will not ovulate, and as a result, she may have irregular menses. The ovaries will not perform their functions, and a lot of things can happen. Infertility. A woman may not get pregnant simply because she has endometriotic nodules. Some endometriotic nodules can kink the tube from outside. Some of them can even occupy the tube and block the tubes. And without the tubes, remember I said it, pregnancy cannot occur. Some can
Yeah.
drag the tube abnormally. Some can drag the uterus away from the ovaries, can cause pelvic adhesions, chronic pelvic pain. You know,
Mm,
because I told you that endometriotic nodules can be found anywhere. It can be in the lungs, and the patient is coughing out blood every month, and you think the person has tuberculosis. Somebody might
mm,
be having brains, can be having seizure disorders, can be having intractable headaches, simply because
mm,
he has some endometriotic nodules in the brain. It
mm,
can be anywhere. It can be on the
mm.
gastrointestinal system. So
Wow.
we
Wow.
follow through that.
Thank you so much for breaking it down for us. Because the reason why I had to ask that question was because a lot of time when we get dismissed like that, we just go back and just accept our fate. And that's exactly what happened. Everything I have painted was my story. I had blocked tubes, it prevented me from conceiving and all that and all that. But when I was dealing with the pain at the early stage, I was being dismissed. They were saying it's all up in my head and everything. And at the point, I was just like, you know what? Maybe this is what I have to deal with for the rest of my life. Maybe this is just normal. And so one of the reasons, and I want our audience to hear this, one of the reasons why I'm asking this question is for you to know that even when you are being dismissed and you have those symptoms, those signs, it's for you to know that it's not normal and you need to go back and check and ask, get second opinion, third opinion. It's very common with endometriosis patients. We don't stick with one doctor. When you are not there with that doctor that has the right diagnosis, please keep getting other doctors and opinions from other medical doctors, specifically gynecologists. I'm saying it now. So that's one of the major reasons. We have two questions here, and I want us to run through it before we head. Number one says, my period used to last 5 days, but now it's barely 2 days. What could be the cause?
Well, 2 days period is still normal. If it's less than 2 days, then there's a problem. But I think 5 days, the most important thing is the volume of blood that is lost during menses. An average menses to take out about 80 mils of blood from the woman. So how many pads does she use during those 2 days compared to what she used when it was 5 days? Yeah, but some books will say 2 days and below is abnormal. But what if she, when it was 5 days, she uses about maybe the first day was not heavy, the second day was heavy, and it ends on the fourth day, and on the fifth day it's just few drops. So the volume of blood she loses during the 5 days may actually be comparable to what she lost in 2 days. So if it's actually significantly less, if it's reduced hypomenorrhea, or the volume of blood is reduced, the number of days are reduced, that's oligomenorrhea. Well, it might be that the patient is not ovulating. If the patient is not ovulating, it's the ovulation that causes the secondary thickening of the endometrial lining that makes significant volume of blood accumulate on the endometrial layer from progesterone influence. Because let me just break it down. The cycle is divided into two. Immediately after the menses, there is this proliferative stage of the menstrual cycle where estrogen comes and repair what has been shed in the last menses. It repairs the endometrium, prepares everything, and causes primary thickening of the endometrial layer, and that is really insignificant. At ovulation, mid-cycle usually, or the last 14 days of the cycle, when ovulation occurs, progesterone comes out and causes a secondary thickening on the already primary thickened endometrial layer prepared by the estrogen. And that secondary thickening is actually very significant. It's huge, it's big, it's the real waterbed. So, but if that event doesn't occur, the patient will not bleed much. So that means
Mm,
it might attend to the fact that, oh, this patient didn't ovulate. Like, for example, some people gain weight suddenly, and the androgens in the peripheral fat interferes with ovulation, suppresses ovulation, and they'll just bleed scantily. So I think the patient will need to see us. Merely looking at the patient walking into your clinic, you start having your diagnosis in your head, even before the patient speaks. ONG is very
mm,
interesting. So as she's walking
mm.
towards you, this is most likely an androgenic patient, an hyperandrogenic patient, or a PCOS patient, or this blah blah blah. It starts coming up. And by the time she sees us, we can actually help. So if it's ovulation
Okay.
that's the issue, we'll solve it.
All
And
right.
many
So,
reasons, sometimes the uterus might have been gummed together, what we call Asherman syndrome. It might be a complication of some procedures that have been done. Now could also cause significantly reduced menstrual flow, and many others. So I think the client needs to see us, any gynecologist anywhere, will be able to do justice to that in a jiffy. It's a piece of cake, honestly.
mm. So please, the person that asked that question, please see a gynecologist. And if you have any follow-up question, um, send us a DM. I think our contact information, our contact number at LifeBloom should be pinned somewhere on YouTube and on Facebook. Send us a message and we'll um, send it to Dr. Ayo and see if he can give us an answer. But before then, try and see a gynecologist to see what they can help you with. The second question we are having more question coming in now. Another question we have here says, I have hair growing out in my chin. Should I be worried about having PCOS?
Yes, you should. Hair growth on the face is actually due to what we call high level of androgens. There are different hormones in the body, and I don't want to start using medical jargons, but androgens are male hormones, and it's males that typically grow hair on their chin, on their chest, and we have male pattern of hair distribution on the tummy, and the male build. So, but in some women, they have high levels of androgen. So if that happens, depending on the level and depending on the body response, the patient may be having challenges in ovulation. Androgen negates ovulation because guys don't ovulate. So if the androgen level is high enough, it can suppress the ovaries. It
Hmm,
prevents its follicular growth, and the patient may actually have challenges achieving pregnancy. But that doesn't occur in all cases. There are some patients with high androgen levels, but not high enough to arrest their ovulation. So some still ovulate, they get pregnant, and they are fine with it. So it depends. So if the asceticism or the abnormal hair growth in all those other places, if it has um, other family members, so to speak, you should see us. Most especially when the patient now doesn't menstruate regularly. Then you can see that, oh, it's likely this patient is not ovulating too. So is the androgen levels that's causing it or is not, blah, blah, blah. Then we can do an ultrasound. Then we can see the ovaries. If the ovaries are under the influence of androgen, there's a way they look. We call them polycystic ovarian features. When you see the ovaries looking like it's wearing a bead, you see about 12 follicles and more, arranged in a bead on string pattern on the ovaries. Each of these follicles are very tiny, about 2 to 9 millimeters in diameter. And it's simply because they want to ovulate, the androgens are arresting them, so the ovaries keep pushing them to the periphery. So the ovary actually looks laden with follicles arranged at the periphery, and it's so classical. If you Google it, PCOS in ultrasound, you see the image on transvaginal ultrasound. So all those things are there. So, and we can come in handy to actually help. And it's again a piece of cake. It's not a difficult thing to induce ovulation in such a person, depending on what she wants. So if it's to get pregnant, we work around it. we induce ovulation, and we can help the person get pregnant.
Thank you, thank you, thank you so much. We have two more questions, but before we go, I just want people to know if you're just joining us, you're welcome. I'm sure that you'll be able to go back later on and rewatch the video, whether on YouTube or on Facebook. But like I said, this is our first Ask the Doctor. Um, Starting this January, we're going to be having this on a monthly basis. So it's going to be every third Sunday of the month at 6 p.m. So, come with your question, invite people, share this platform, LifeBloom, just share it. You will see all our pages. Help us to share it. We want people to learn. We want people to get clarity. We want people to get understanding of these medical conditions, so that they can know what next to do. And we'll be bringing doctors here. Not only Dr. Ayo has come, and he will come again next month. And we have some other doctors that will also be joining us, to come and help us. We're not going to be only talking about endometriosis. We're going to talk about endometriosis. We're going to be talking about PCOS. We're going to talk about infertility, fibroid. We're going to talk about how all these things affect our mental health, the place of nutrition, and holistic wellness generally. So please, I want to encourage you to please help us to share it. We're trying to create awareness about all these conditions. Thank you so much. All righty, let's go to our next question. The next question is it advisable to use CQ10, folic acid, vitamin E drugs for a TTC mom, a trying to conceive mom?
What is CHQ?
C C H CQ10. I think it's a
What?
medication,
Well, I'm not aware of what CQ10 is.
but
I'm
it's
interested
C.
with
She
just
said CQ10. Oh, no, the person wrote CQ10, but maybe it's COQ10. Folic acid,
yes.
vitamin E drugs for trying to conceive
Yeah. Well,
mom.
I know what CHQ is, but I would disallow. I will advise person not to. But folic acid is valid. Vitamin E is beautiful. Yes, I agree. Folic acid has a way of, um, replenish folate stores and preventing neural tube defects, because usually before people know they get pregnant, that if there's a folate deficiency in a woman, before you discover that you are pregnant, the damage has been done. And majority of first trimester pregnancy losses, that's in the first 12 weeks of pregnancy, are due to chromosomal abnormalities in the formation of the embryo. In the first 8 weeks, when the pregnancy is just trying to come up, there are errors. And what causes the error most, in most cases, is folate deficiency. So a woman that goes into pregnancy with folate deficiency will usually come down with spontaneous pregnancy losses in the first 12 weeks of pregnancy. So if a woman is desirous of pregnancy and is taking folate, beautiful. Yeah, because the folate will just be there and everything will be cool. Then vitamin E is an antioxidant that helps mop free radicals in the system that could cause adverse pregnancy outcome, which is also very good. But I wouldn't know what CHQ is, but I would advise the person not to take it, because I really don't know what it is, and I can't really put my head around any drug that can hate pregnancy outcome that looks like CHQ. The only thing that comes to mind right now is chloroquine 10 tablets, which is bad. It's an anti-malaria. Why should somebody take it? So folic acid is it. Vitamin E is good.
All right. All right. Thank you so much. So for that person, please, the other medication that you ask, please consult with your gynecologist before you take any medication. Thank you so much. The last question that we have on here is, can one go for a fourth laparoscopy excision surgery after a successful IVF cycle?
Fourth after a successful IVF,
Cycle.
what's the person going for laparoscopy for? To excise
So,
endometrium?
can that person? explain that question a little bit more. But from
Has
what
she
I'm
done any
explaining,
laparoscopic excisions before? Because she's talking
she's
about the
saying that she's saying that if, I think the question is saying that can you go for fourth one
has she
after
done
you have
three
done? So I
before?
think she has done three before, and then
And
she
now
did an IVF. Mm-hmm.
which is successful, she has a baby now, or
Mm-hmm.
she has now.
Yes.
Well, if she had done three excisions, like endometriosis keep growing, and she now has children, why don't she just, one of the managements of endometriosis is to induce menopause. By the time you render the patient menopausal, the endometriosis nodules will atrophy and they will disappear. So why going for another excision when you know that it's going to grow again? And now you have your babies, just go menopausal. There are drugs that will render you menopausal without any issue. You just suppress the ovulatory system and you will not menstruate. There's so many of them, and they are so readily available. They will shut down the events in the uterus, shut down the events in the ovaries, then you live your normal life. Because every procedure carries their own risk. And now that you have done three, I'm sure with the successful IVF, you may likely have a cesarean delivery. Now you've had
Mm-hmm.
four, you are going for the fifth one. Each surgery carries its own risk, and the more surgeries you do, the more risky they become. So, and if there's a drug that can actually help you, or there's some medical management that can help you, why not? As specialists, you must give patients options. You give them options of this, options of that, options of this. So if she were to be my own sister, I'll ask her to go for the medical management there because she has done three surgeries, laparoscopic procedures, one major surgery, and all that. So, in fact, the chances of pelvic adhesions is there too because of the cesarean section she has done.
Yes.
Endometriosis predisposes people to form pelvic adhesions. So the laparoscopic procedure becomes more difficult, and injury to adjacent structures and all that can readily occur. So why risk it? So you
Yeah.
should gynecologist that, why don't I go menopausal rather than going under the telescope all the time? Yeah.
I totally agree because honestly, that was my story. I had series of surgery before I had before I did an IVF and had my first daughter, and between my first daughter and my second daughter is a gap of 10, 11 years, and in
Yeah,
between those two, I had a couple of other surgeries. So by the time I got pregnant with my second daughter, it was a complicated pregnancy and delivery. You understand? But
yeah,
I also understand. I As much as I understand what you just said and where you're coming from. What about somebody like me that have only one child, and I want more?
yeah. If you want more,
So
do
if I want more, the
do the
the
basic.
advice you just gave would not be the right.
Yes, but Funke, please wait. You can suppress ovulation temporarily. It doesn't have to be permanent.
Yes.
When
Yes.
you go into menopause between 45 and 55 years with an average of 52. So if you are way beyond younger than that, you can suppress it temporarily. And when you want to do your IVF, you take out the drug, you do your procedure, you go back menopausal again. Do you understand
Okay.
what I'm trying to say? So
Okay.
we understand
Yeah. So now I understand.
that we can play around it. Now, you don't have to suffer. You don't have to keep having those pains. You don't have to go under the knife. Just suppress the ovulation. When you want to do your IVF, you super ovulate. You take over your cycle, harvest your eggs, do your embryonic transfer, you deliver your child. Then you go menopausal again. You don't understand? But if you want actually to get out the endometriotic nodules, you can, depending on the symptoms you are having. If the pains are unbearable, yes. Or if you
Mm,
go menopausal, you still abate. But there are some that will have caused permanent pelvic adhesions that you will actually need to go in and release those adhesions. There are some
mm,
of the endometriosis that will be on nerves, you know, on the pelvic nerves that you may
mm,
actually go in actually denervate some of the organs in the pelvis. So there are always options. There are always escape routes, and
mm.
that is why we are here. We are your formidable friends. We are your friends. We are gynecologists. We are here for you. And we are just a call away. And we are happy doing what we do, honestly.
Yeah.
Very happy.
Honestly, I can tell you for a fact that Dr. Ayo is one of the few doctors that I know that is so happy, excited, doing what he's doing, you know, and he feels fulfilled in it, and that pushes what he does. And I am so truly, truly honored and grateful that you are able to join us. Dr. Ayo is part of our LifeBloom family, so you'll be seeing him a lot on this Ask the Doctor channel, or that Ask the Doctor episode every third Sunday. But sometimes we'll give him a break so that some other doctors can come on board. And this is where we will be wrapping up today. We want to thank everyone that has joined us today. Thank you so much for sending in your question. Keep sending them in. Keep sending them in. We will ask them on one of our episode of Ask the Doctor. If it's something that is urgent, please put in there that it's urgent, and we will reach out to Dr. Ayo and see if we can get a clarification on it or answer for you. But once again, I want to thank you all for joining. Please continue to follow our page. We have a lot of things that we're rolling out in this year. Continue to follow us on different platforms. We're on Facebook, on IG, on TikTok, on YouTube, on Twitter. So please follow us. You will see what we're doing. We're coming up with our campaign schedule information. You will, if you would like to volunteer to be part of our campaign, creating awareness, helping people to come out of pain, to let them know that pain is not normal and they don't have to live in pain for the rest of their life. Please reach out to us, and we would love to have you on board. Again, I want to say thank you so much, Dr. Hayo. It's been a pleasure for of having you on this show today. Thank you so much. And this is where we'll draw the curtain today.
Thank
Thank
you
you all,
very.
everyone, and I'll see you again next time. Bye and God bless.
Thank you. Bye.